The WHO Guide, Making Every Baby Count, Audit and Review of Stillbirths and Neonatal Deaths, was published in 2016 and is a practical guide on how to set up and conduct facility-based reviews of perinatal deaths. There is a need to strengthen counting perinatal deaths and the causes of deaths, but also understanding why they occurred and what can be done to prevent future similar deaths. Through this video, let us give you a short introduction. What are the aims of the Guide for Audit and Review of Stillbirths and Neonatal Deaths? First of all, it contributes to establishing a framework to assess the burden of stillbirths and neonatal deaths, causes of death and trends in number and causes of deaths. It will also help to generate information about modifiable factors and aspects of care that can be changed in order to prevent future perinatal deaths. Other important outcomes are making stillbirths and neonatal deaths visible to decision makers and provide a mechanism of accountability. What is a perinatal death? First, we have to start with the definition of stillbirth. There have been varying definitions over time and across settings. For international comparison, WHO uses the definition of a dead-born baby of 1,000 grams or more after 28 weeks, or a body length of 35 centimeters or more. In high-income settings, the viability of babies as early as 25 weeks is a fact, and therefore for national use, the definition of birth weight of 500 grams or more after 22 gestational weeks or greater, or a body length of 25 centimeters or more, is also used. The stillbirth rate is defined as the number of stillbirths per 1,000 total births. Stillbirths can be categorized according to when the deaths occurred. Antepartum stillbirths occur before the onset of labor, and intrapartum stillbirths occur during childbirth. It may yield information on when the deaths occurred, but not why. Intrapartum stillbirth rate can be used as a measure for quality of care. What is a neonatal death? A neonatal death is a live-born baby who dies within the first 28 days of life. Neonatal deaths can be divided into early and late neonatal deaths, where early neonatal deaths comprises the first 7 days of life and accounts for 75% of all deaths. Late neonatal deaths occur after the first week and up to 28 days of life. The neonatal mortality rate is defined as the number of neonatal deaths per 1,000 live births. Perinatal mortality includes deaths from stillbirths and early neonatal deaths. What is audit and review of stillbirths and neonatal deaths? In a multidisciplinary approach, it is a process of to collectively reviewing all available information about a stillbirth or neonatal death to arrive at the cause of deaths, identify other non-medical factors which could have contributed to the death and, if addressed, may prevent deaths in the future. This should occur in a blame-free environment, assuring no punitive actions. The overall objective is to produce better data, increased awareness, and eventually a decrease in stillbirths and neonatal deaths. What are modifiable factors? A modifiable factor is something that may have prevented death if a different course of action had been taken. An example is having a bag and mask available for neonatal resuscitation, but a missed opportunity if no staff has received any training in how to conduct resuscitation with bag and mask. There can be more than one modifiable factor associated with each death. There are multiple methods for identifying modifiable factors such as root cause analysis, 3 delays approach, or the system-level approach. What is the relationship between mortality audit and the wider health system? Perinatal death review provides the opportunity to identify the actions that must be taken to prevent future perinatal deaths. Number of perinatal deaths alone cannot provide the clinical information necessary to understand how the deaths might have been prevented or may be prevented in the future. The identification of deaths will contribute to strengthening civil registration and vital statistics, or CRVS. Coverage and reporting of deaths will contribute to being able to track mortality trends, and reviewing and responding to deaths will strengthen how to measure quality of care for improved service delivery and outcomes. What is audit and review? The audit and review cycle consists of 6 steps: identifying cases, collecting information, analyzing information, recommending and implementing solutions, and evaluating and refining. What preparations are needed before setting up a stillbirth and neonatal death review committee? Before setting up the system, it is important to review what other initiatives are already in place and build on that. Secondly, everyone should sign a meeting code of practice to adhere to common rules of confidentiality and mutual respect. It should be a multidisciplinary team consisting of clinical staff such as nurses, midwives, obstetricians, neonatologists, or pediatricians, as well as facility and district managers. And in some cases, community linkages are necessary. The focus is on improving the health system and not blaming individuals. Legal and professional disciplinary processes should remain separate from the death review process. The first step is to identify cases. The goal is to identify all births and deaths to create a list of all stillbirths and neonatal deaths in the facility to improve capturing of cases for review. This information will build the so-called minimum perinatal dataset. The first step is therefore to identify the sources of information to be able to identify all the cases. There are some important questions to be asked. Where are deaths likely to occur in the facility? And are the records found in different places across the facility, for example, in the delivery, postnatal and neonatal ward, operating theatre and pediatric wards for late neonatal deaths? The second step is to collect the required information. Ideally, the review should take place within 1 week of the death, and only necessary data that will be used for analysis should be collected, and all additional information that can create a richer understanding of delays. Data verification should be made before exporting data to a higher level. One benefit of capturing data electronically is the ability to build in quality checks to minimize data entry errors. The third step involves analysis of the information collected. Selecting cases for review is being discussed in a separate video. Minimum indicators to follow over time are number of maternal deaths, total number of births, number of vaginal deliveries, number of caesarean sections, antepartum and intrapartum stillbirth rate, in-facility stillbirth rate and in-facility neonatal mortality rate. More information could be gained from geographically mapping key details related to specific indicators. For example, women presenting with obstructed labor may present from a specific area, or there may be issues in accessing the facility that might become evident when looking at a visual representation that shows clusters of cases from certain geographic locations. Further, qualitative information about modifiable factors. Analyses can also take place at different levels, such as analyzing the information on the individual level only or the facility level. The fourth step involved recommending solutions based on the analyses done. Recommending solutions is the most difficult part, as they should target actionable problems, factors, causes, and sub-causes. The solutions can be at facility level, community, district or national level, and can also have different time frames such as immediate, medium, and long term. The dissemination of key audit findings should target those who can implement change, and a periodic report should be written in a simple language with findings and solutions. The fifth step involves implementation of changes. Implementing the changes is the whole purpose of the action cycle. Actions should be assigned to team members of the committee with clear time frames. Leadership is important to ensure that recommendations get implemented. The sixth step involves evaluating and refining of the changes. Periodic evaluation is important to understand how efficient the system is in identifying and reviewing the deaths, and also how effective is the system in institutionalizing beneficial practices. Therefore, it is important to document changes over time through an annual review meeting or report, helping to identify gaps or areas of success, and also the inequality of the information captured. For more information, please visit the WHO website. WHO thanks sincerely all the experts who contributed to the elaboration of the Guide for Audit and Review of Stillbirths and Neonatal Deaths, making every baby count.